My name is Destiny LaDuff, and today I'm going to be presenting a 12-year-old adolescent girl who presents to the clinic accompanied by her mom and dad. ST presents to the clinic today with mom and dad, stating that she has had poor grades in school and has consistently been disruptive in class this school year. The last 2 school terms have been challenging for her to focus in class, as she finds herself often thinking about what she will do when she gets home and what she is going to eat. She also has a lack of interest in doing her homework and classwork and states it's boring. Over the last 2 school terms, her mother states she has been constantly misplacing her school supplies. A more worrying concern is that she has had trouble with redirecting her at home, and she has never been like this. She also fidgets a lot and has become clumsier at home and in school. She also complains that she feels targeted for being listed as a noisemaker in class each day. Mom states the teacher has mentioned that she is frequently blurting out the answer before being called on. Her history of present illness. Over the past 2 weeks, she has had problems falling asleep. She is fidgety in bed and states it takes a long time to fall asleep. She sleeps an average of about 5 hours per day. States that she goes to sleep around 1 in the morning and has to wake up again at 6. She has a decreased interest in activities, especially with classmates in school, finds that she is no longer interested in playing. ST normally enjoys cheer and volleyball, and the last time she did or participated in either of the two was about 2 months ago. She was kicked off the volleyball team for being aggressive to other players and talking rudely to her coach. She has frequent crying spells over slight provocation. She has increased energy levels that manifest through excessive disruption and blurting out in class. Her concentration is reduced in class and during conversation at home. She has a decreased appetite with a 10-pound weight loss over the past couple weeks. She has high agitation levels, although she denies any suicidal or homicidal ideation. She reports no auditory or visual hallucinations. She does report racing thoughts and increased flight of ideas over what high school she would want to attend. She states she feels very restless, as if she's supposed to be doing something. She feels like she's constantly forgetting something, which makes her very anxious. She does feel safe in her environment. ST has no psychiatric history. This is her first time presenting to a clinic. No past medical history, no surgical history, no known drug allergies, and is currently taking no medications. She denies any history of substance abuse, and there are none recorded in the patient's profile. Her family medical history: mother has type 2 diabetes, father hypertension, and sickle cell anemia from the father's side of the family. Her family history of mental illness: her brother has suffered from bipolar and generalized anxiety disorder, and her uncle suffered from substance abuse disorder, cannabis, and alcoholism. Social history: ST is single, no children, currently lives with her parents and 2 brothers. She is the youngest child. She is in 6th grade in a new middle school. Has had no encounters with the law and no school suspensions apart from normal detentions after class. She does report recent transition to this new school as they moved to a new neighborhood prior to school starting. She states she has been a little anxious with the move, as she now has to acquire new friends and adapt to a new environment. ST was born in Shreveport, Louisiana. She is currently being raised by both of her parents. Her childhood has been fun, as her parents can afford to take her to points of interest and fun places. She enjoys partaking in activities and playing games with friends in her spare time. She has friendly neighbors with whom she plays with and goes to the same school with. It is safe to say that ST has a healthy social life. ST denies any form of trauma inflicted on her and believes that home is a safe space for her. She only complains with when her parents are strict with her. Legally, she has no history of legal problems. Habits: lately ST exhibits a high intake of soda and fruit juices, saying that she needs a sugar rush. She denies any history of emotional, physical, or sexual abuse. Her vital signs are all within normal limits: temp 98.9, pulse 80, respirations 25, blood pressure 120/65. She's 97% on room air. Height 51 inches, weight 32, a BMI of 20.9. A general review of systems: she reports a weight loss of 10 pounds over the last 2 weeks, no chills, no fevers. HENT is normal, respirations are normal, cardio is normal, GI is normal, General review of symptoms is all normal with the exception of reduced sleeping hours. A mental status exam. Patient appears anxious with hyperactive psychomotor activity and pacing around the room. She makes brief eye contact and attempts to engage in conversation, but is very easily distracted. The patient is cooperative, but mood is irritable with repeated questioning effect, and she appears very anxious. Short-term and remote memory are intact. She is able to recall what she ate for breakfast and her first grade teacher's name. Her speech is rapid but organized. Thinking is circumstantial, denies delusional thought. She denies suicidal ideations without plan or intent. She has good insight, but her judgment is impaired. Patient is experiencing a minor manic episode, and she is aware her behavior is inappropriate, but feels compelled to continue, as if a motor is pushing her to go. My plan for her would be labs, CBC, CMP, HIV, RPR, TSH, BUN, creatinine. They were all within normal limits. UDS and UPT are both negative. A EKG was performed that showed normal sinus rhythm. ST stressors are physiological, intrapersonal, anxiety, depression, poor appetite, and insomnia. The interpersonal physiological stressors are a lack of focus, easily distractible, and irritability. Her extrapersonal physiological stressors are a recent move to a new neighborhood. Intrapersonal psychological stressors are anxiety and depression and irritability. Interpersonal psychological stressors are a new school transition. Extrapersonal psychological stressors is new grade, middle school, and new teachers, and also new home environment. Sociocultural, intrapersonal stressors are physical independence of moving away. Interpersonal, sociocultural, moving to another neighborhood. Extrapersonal, sociocultural, are new friends and adjusting to new teachers. Intrapersonal developmental stressors are independent and self-sufficiency. Interpersonal developmental stressors are new self-identity and starting a middle school. Extrapersonal developmental stressors is a new school and being away from her old friends. Spiritual stressors, intrapersonal is that she believes in God and then she is a person of faith. Interpersonal spiritual stressors, she feels attending church is important. And extrapersonal, she attends services on holidays and special occasions. According to Newman's model, the patient's condition has penetrated her flexible line of defense and normal line of defense and lines of resistance, as evidenced by increased anxiety, insomnia, alterations on thought pattern and irritability, poor appetite, and weight loss. Differential diagnosis for ST are acute stress disorder. Positive symptoms of that would be manic insomnia, irritability, decreased sleep, increased psychomotor activity, rapid speech, and impaired judgment. Negative symptoms would be negative drug screen, and a TSH is within normal limits. Another differential could be depression. Positive symptoms of depression: manic symptoms, insomnia, irritability, decreased sleep, increased psychomotor activity, rapid speech, impaired judgment. Negative would be a negative drug screen. Another differential is a mood disorder caused by a general medical condition. Positive signs of that would be decreased concentration, irritability, insomnia, and recent antidepressant use. And a negative symptom is the negative drug screen, and her TSH is within normal limits. My final diagnosis for ST is acute stress disorder, as evidenced by alterations in the thought process, alterations in nutrition, and alterations in her sleep pattern. The goals for ST are resolution of symptoms, decreased symptoms of mania, normal thought process, decreased irritability, and decreased psychomotor activity. She should have improved nutrition, as evidenced by the achievement of weight back to baseline. She should have improvement of her sleep alterations, as evidenced by patient and family reporting 7 to 8 hours of uninterrupted sleep. My primary interventions would be to incorporate positive measures to become acclimated to a new environment. I would include health promotion measures that are taken according to Healthy People 2020. I would educate and screen on substance use, stress and depression, suicidal risk, decrease caffeine intake and decrease sodas, good sleep hygiene, and identification of her stressors. Secondary interventions would be referral for psychotherapy and referral to a PCP in a new area to establish care, resolution of symptoms, follow up in 4 to 6 weeks to assess, discuss with parents being supportive and assisting her to become acclimated throughout this new change. Tertiary interventions would be recommending omega-3 vitamin for its neuroprotective benefits and a multivitamin, referral for family-focused therapy for coping mechanisms, weekly weights for maintenance of weight, and possible referral to nutritionists. Based on Hamrick's nursing competencies found in Tracy and O'Grady 2019, the APN competencies utilized in this case are direct patient care by obtaining an H&P in diagnostic studies. Collaboration involves working with the primary care provider and referral for psychotherapy. Education and guidance is done as the client is educated on coping mechanisms to incorporate into her daily life to help with this new transition. Also educated on the use of multivitamins and omega-3. Parents also educated to be supportive throughout this time. Meds, there were no meds started at this time. Educated that we will follow up at the next visit to determine if any medication needs to be started. Inventory of the patient's assets and strengths. She has a general fund of knowledge, above average. She's intelligent, a very poor sense of humor, has supported family and friends, great physical health, is motivated for treatment growth, incapable of independent living as she lives with her parents. She has limited availability for insight, average communication skills with over-talking, has no financial means as she is underage and lives with both her parents. She is a Christian. Hobbies and interests are likes to swim, cheer, play volleyball, draw, and paint. She works, volunteer skills are none. Inventory of her liabilities. She has poor judgment, limited insight, and average cognitive abilities. ST was diagnosed with acute stress disorder. Thank you.